So this is going to be, it's a pleasure to be here. I love this meeting. I absolutely love this meeting. I go to many of the other meetings, but this one is special because I've been to it for so long. So I've seen the patients, many of my patients grow up, and they're growing up together with all of the friends that they meet here. And I think it's really important to have that. The camaraderie that you all have is just really amazing. And it really is important for us to see that because it helps us continue to do our job to find a cure for you all. So I did give this lecture last year. It was a talk that I think I gave through, I had to stay in at CHOP. So I really would like it to be interactive though. So if you have any questions, just raise your hand. I wish I had a mic that I could walk around with, but I really want it to, if you... Oh, okay, because it might be better than just standing up here if you're okay with that. I don't mind, but how am I going to change the? It's okay. I'll just do it up here. So, but just interrupt. Just raise your hand if you have a yes.
Anybody else had lymphatic malformations appear after infection? Like I get my lymph nodes turn into rocks along my shin when I get really sick and they get raised. And I've been told nobody else has ever had this except for Civil War amputees.
We would have to look at you and see, but there have been people who have a lymphatic component and don't know that they do. And I'm going to talk about that a little bit, like when we talk about sort of what the phenotype is. And after an infection, there's a lot of inflammation that happens, and that may be when that appears, you know, when they finally say, aha, this is part of the problem. So, yeah. I do consult, so I do have some consultation that I do because we need to be consulting with pharmaceutical companies, we need to be consulting with other foundations, because in order for us to get medicine, so I am an oncologist, I'm a pediatric hematologist oncologist. I think I've talked about sort of how I got to where I am. Brian talked about how he got to where he was yesterday. But I was a fellow. So a fellow is when you're already a pediatrician and you want to be a hematologist, oncologist, and you take some extra training. It's usually 3 or 4 years. And when I did my fellowship, I did it at Duke University, and I did it in my clinic was down the hall from a dermatologist. Neil Prose was this dermatologist's name, and he was a wonderful, wonderful dermatologist. But he kept sending patients to our clinic to check the spleen out. I think this is a hemangioma, give interferon. And in the olden days, we didn't have like electronic medical records, so our charts were in piles. So we would walk into clinic, we didn't know who we were gonna see that day, we'd pick up a chart and we'd open it up. And every time I went to my clinic, I'd pick a chart and I'd open it up and it would be another hemangioma. So everything was a hemangioma. And when I went and I looked at the patient, I said, now I sort of remember a little bit, so this is back in the 1990s, right? I remember a little bit in medical school, which was in the 1980s, about all of this, but I don't really remember all of this, and this doesn't really look like a hemangioma to me. So what I did is I went to the library at Duke, and I became really good friends with the librarian, and she, every week, would get me articles that were written on vascular anomalies. And many of the articles were from Boston Children's Hospital, and they weren't from hematologist oncologists, they were from surgeons and interventional radiologists. And I decided to call Boston Children's Hospital, to call John Mulliken, who's a plastic surgeon, and I decided to basically go up there as a fellow. And I was in a lab too, doing other things, but this sort of was something that was really of interest to me. And so I went up to find out what vascular anomalies were, and that's how I got started. And when I started it, I also was taking care of patients with cancers. Like I take care of patients with vascular cancers. There are these things called angiosarcomas that I take care of, and these other very, very rare things called pseudomyogenic hemangioendotheliomas and all of that. They're all rare that I still take care of. But after a while, I became very frustrated that I couldn't give my patients what they needed, the vascular anomaly patients. I couldn't give them what my oncology patients were getting. So this is sort of an outline of what we're gonna talk about, but again, just any questions that you have. So way back when, in that period of time, I knew that vascular anomalies were either tumors because they were growing or malformations. Everything was really called a hemangioma because we weren't really looking with the pathologist under the microscope. So there was some pattern recognition. So if you came in and you looked like someone else that some other doctor had seen, they would sort of lump you all together. There was that simple classification system, many surgical and interventional procedures. And I remember being up in Boston because I eventually went to visit them, and I would go every month for a week to work in their clinic. I would see patients and I would say, how do you know that this surgical procedure worked? Like, what is the pain better? Is the functionality better? I'm not understanding. Because that's how we thought as an oncologist. We give medicines and we make people better. We have outcomes that we follow. We didn't really have any of that. And so I would ask these questions in their clinics and in their research seminars. There were really limited medicines. There were no clinical trials. There were no cooperative groups. So being a pediatric oncologist, we had this big cooperative group called the Children's Oncology Group, where in every single major medical center, and even the smaller and the very small medical centers, you really couldn't be treated for a pediatric oncologic diagnosis unless you went to one of these centers because they had protocols for you. They had the latest and the greatest of what to do. They were doing research. And I found none of that. But today, so that's, in the 1990s, today in 2024, we have a much better classification system that keeps changing. We have standards of practice that we're thinking about, like how do we as a group take care of people so that we know that someone from CHOP is being taken the same way as someone from Nebraska, as someone from California. We have these multidisciplinary clinics. I remember I call them interdisciplinary because in some places we all meet together. We have some medical therapies, but we certainly do not have enough. We know what we're looking at, and that's called the phenotype, and I'm going to explain that. We're getting to know what the genotypes are, and we have some clinical trials now, and we have some clinical trials for medical therapy. We need more clinical trials for interventional therapy. We need more clinical trials for surgical things, and we're trying to get biomarkers. So biomarkers is a simple way to figure out, you heard the wonderful talk about genetics. But we need to do more than just having to biopsy something. Like the cell-free DNA will help us to have us understand what a person has so we can fit it all together. So this was a simple classification that I knew when I was working with John Mulliken, who came up with this classification in 1982. And this is a reiteration of that classification. And this is from the International Society for the Study of Vascular Anomalies. So again, if you want to see that classification, go to that website. If you want to be part of this group, because this is an international group, go to that website. It's really an amazing meeting. In 2 years, that meeting's going to be in Philadelphia. But this classification has been reiterated so many times. And that's not, I say it's not because we're confused, but sometimes we are confused, but it's because we're gaining more information about these disorders, and it's exciting. We're changing things. We're changing where things should be. And the thing about it is that this has been very hard for everyone when these diagnoses changed, when the genotypes came about, because many people were at patient support groups like this, and when all this stuff came about, and I'm going to talk about it a little bit, like pros, people felt, I'm not in the right place. Well, guess what? You're all in the right place because you all have vascular anomalies, and you're all being taken care of by vascular anomalists. So I think that was really hard at first when all of these changes came into play, but the bottom line is that you all have vascular anomalies. So these are tumors, and this shows you that tumors are different too. So even though tumors should be more straightforward, look at the heterogeneity. Those are all classified as tumors, but they all look very different. They're all treated a little bit differently. So we really need to know what it is that we're looking at and what things we need to be worried about. And these are all vascular anomalies. All of these people need all of us, right? It doesn't matter that one of them is a complicated lymphatic anomaly. It doesn't matter that one of them is just a straightforward venous anomaly. The same issues that you all go through are the same issues for everyone. So what's the history of overgrowth syndromes? So remember we talked about sort of in the 1900s when people found a pattern, when physicians found a pattern, they would kind of lump those patients together. And it helped, it really did help, and they would report on them. And they would usually give them the name of the people who sort of lumped them together. So Klippel-Trenaunay syndrome was French MDs who described a capillary stain that they said was a hemangioma. We know now it's really a capillary stain or a capillary malformation with venous varicosities, so veins that were dilated, that were bigger than a typical vein, and sometimes those veins are sort of extra veins or what we call embryonal veins, right? And many patients also had lymphatic problems as well. So if you just looked at what KT was, it was either a capillary, venous, a lymphatic malformation, because there's more veins than lymphatics, or a capillary lymphatic venous malformation, okay? But sometimes people fall a little bit out of that. Sometimes people, we don't know they have a lymphatic problem until later on. Sometimes people most definitely maybe don't even have the lymphatic problem, but they still are a mixed vascular anomaly. At that, yes?
When I was diagnosed in 1968, they called it Klippel-Trenaunay-Parks-Weber syndrome with all four of them together. So
Yeah.
are you going to talk about the difference between them?
Yeah, so right here is at the same time, there was an English dermatologist who described what they thought was Klippel-Trenaunay with a high flow nature to it, right? So if you put your hand on it, it was warmer. The capillary malformation was not as blue, it was more bright red. And if you looked, there were little AV, they call them AV shunts, so not necessarily AV malformations, but like AV malformations. And that's where the W part came into play. But that's not, so Parks-Weber is not KTW, right? Because KTW is really Parks-Weber syndrome. It's a RASA1 mutation. It's totally different, but it's still a vascular anomaly. So those that have RASA1 who are here need to be here, right? You need to be here. But it's very interesting because it doesn't go along with that Klippel-Trenaunay. And we're applying for a grant this year. It's called a U54 grant, and this is the first time, it's a big consortium grant. This is the first time that the NHLBI, so that NIH has institutes, and this is the National Heart and Blood Institute. And this is the first time that they included vascular anomaly patients. And so they included KT patients, they included complicated lymphatic anomaly patients, and they actually put KTW. So that goes to show you that even we still need to do some education out there, right? But that's like, again, it's not important because you still have a vascular anomaly that needs to be treated. It's important to physicians, and it sort of is important for you because we need as physicians to know when I go into a room and I see you with this brighter capillary malformation and I put my hands on this and it's warmer and I have my interventional radiologist go in there and do an ultrasound and it's higher flow, that's Parks-Weber, that's going to be a RASopathy. It's not going to be a PIK3CA. And I'm going to need to think about things differently for you, even if this is a baby coming in that I have to watch as that baby gets older versus a Klippel-Trenaunay patient that I have to watch as that person gets older, okay? But you all have vascular anomalies and you all are in this together. So I really feel very strongly about that because I really feel that this did split people when all of this came about, and you all we are vascular anomalies, as I said yesterday, that take care of every single type of patient with a vascular anomaly, and you're here to support, yes, your own diagnosis, but your own diagnosis has overlap, right? There also was this thing called Beckwith-Wiedemann syndrome that was an overgrowth. And this shows you how even the pro side of things can be confusing, because that is an overgrowth syndrome, important to understand because there's a lot of things that go along with Beckwith-Wiedemann. Sometimes they'll have vascular anomalies and sometimes they don't. Usually they don't, but it's associated with other kinds of cancers. So it's really important to know, is this overgrowth like Beckwith-Wiedemann, or is this not because of the cancer predisposition? And then there's this other thing called Proteus syndrome, which came about in 1976, and that's a little different because you can have overgrowth, you can have vascular anomalies, but you can also have these cribiform nevi that are at the bottom of the feet. But sometimes it's straightforward and sometimes it's not. So sometimes people with Proteus can be diagnosed as having Klippel-Trenaunay or vice versa. And then the thing that really kind of, it didn't upset our world, but it just made it a little bit difficult, was something called CLOVES. So congenital lipomatous overgrowth with vascular anomalies, epidermal nevi, and skeletal and spinal issues. That was a diagnosis that was sort of lumped together when people had all of those things. And there were many people who, with CLOVES, probably were diagnosed as having Klippel-Trenaunay. Sometimes it's a little different because you see the feet are a little different in a CLOVES patient than they are in Klippel-Trenaunay. But that CLOVES patient has the same problems that you have to worry about in a patient with Klippel-Trenaunay. So that patient will have some issues orthopedically, that patient will have the same infections, that patient has the same capillary malformations that might leak. So yes, that's probably called CLOVES, not called Klippel-Trenaunay, because Klippel-Trenaunay's, the feet look a little bit different, but you know what? The same sort of things you have to worry about. There have been some very, very rare reports in CLOVES patients that are like that, and like CLOVES can also just be lipomatous overgrowth without those vascular anomalies, that those patients have had a slightly increase for that thing called Wilms tumor, which is a kidney tumor, but it's mostly this kind of phenotype. It's not the subtle phenotype. If there's ever a patient that I'm not sure whether this is like, more towards the CLOVES, but in that area that I think they might have a risk, then it's very simple to get ultrasounds on them, okay? So I'm hoping I'm not confusing you even more, but this is confusing, right? But the most important thing is, what's really important is what you have, and you all have vascular anomalies, okay? So these came about. Now, when all of this started, there was, why is this happening? And there was, and I'm going to talk about this a little bit later, but there was a patient that came to see me that had a tumor, and we didn't know how to treat her. And when I think of as an oncologist, many of our oncology things, we have all the research for them, are linked to pathways, to growth pathways. And when they're linked to growth pathways, we can figure out what the pathway is and try to figure out how to treat them. So a patient came to see us in Cincinnati, us as a group, and we tried what was our standard of practice to treat this patient. This patient had a vascular tumor, a very long word, called a caposiform hemangioendothelioma. And this patient wasn't responding to therapy, and we needed to think outside of the box. So we got together as a team, all of us, our radiologists, our dermatologists, all of the people in oncology, and we thought, is there a pathway that this could be part of? And we came up for several reasons, and I'll explain it a little bit later, that this could be from the PIK3CA pathway. And the only medicine we had to treat if there was a problem, most cancers are upregulated. You're making too much of something. So kind of like what we know now about our things. And so we hypothesized that this pathway was involved, and the only medicine that we had was mTOR and the sirolimus. So we treated her with that, and I'm going to show you a picture of her. But what was happening at the same time is that we asked the people in Boston, and we asked other people, you have tissue from all of these patients. These are not, we do not, these can't be germline inherited because we're not seeing that they're inherited. They must be somatic, like you heard the wonderful lecture about, so I call it the body genes, right? After that egg and that sperm come together, they make, we all have to be human beings, right? So we all have to have muscles and fat and blood vessels, and that's where the problem is. So they have to be somatic mutations. So we kind of talked as a group to have them go back and try to search for these. It was being done at NIH at the same time, and it was being done in Boston. There was a wonderful person called Kyle Kurick, who in 2012 identified that from a CLOVES patient, and it was a CLOVES versus a KT, but it doesn't really matter. PIK3CA was that somatic mutation that was involved. Remember, we talked about that, like sometimes it's hard to find that mutation, but taking that tissue, they found the DNA that was PIK3CA. And then we basically had MCM come, and that's a part of the PIK3CA overgrowth, led to people looking at lymphatic malformations, which was also PIK3CA, and KTS, which was also PIK3CA. So again, you all have vascular anomalies, different kinds, right? So that we have to know that as physicians because we need to know how we have to treat you, how we have to follow you, even when we're doing studies, what we have to look at for response. But you also all have PIK3CA, and there's different PIK3CA mutations you can have, but some people can have the very same mutation and have different the ways that you look, and we call that phenotype. Does that make sense to everybody? So you're all in this together. So this is just the picture that was shown yesterday of this thing called PROS, PIK3CA related overgrowth. And you know what? There's more to this than what is out there, right? And so we focus on PIK3CA overgrowth. We take care of lipomatous overgrowth too, but many of us really focus on the overgrowth with vascular anomalies. So this led to how we can think about the treatment for these. So if you look at the top, that's the sort of the beginning. This is a circle, and so it makes you think that there's two sides to the pathway, right? So it makes you think that there's one PIK3CA side and there's one RASopathy side up at the top, but they're not. One goes one way and the other goes one way, but there's also a lot of interaction. It's very, very complicated. But I actually, and people who are my patients here know that I used to draw this out for them, like to explain it. But now I have this, and so we can give them this and show our patients sort of how things interact with this right now. But PIK3CA, I think, so Tie2's up there as well. So for people with venous malformations, about 80%, a little bit less than that, are Tie2. The other name for Tie2 is TEC, okay, so that's up at the top. But PIK3CA leads to AKT, leads to mTOR, and it leads to growth and differentiation. So guess what? Every single person in this room, whether you're here with someone who has KT or not, you all have this process in every single one of your cells except for your red blood cells. We need it. So we all need this. It is a process in our body. And it just so happens that when we don't know why, and maybe if we find out the why, we'll be able to sort of cure things, but in you guys, in the areas that are involved, you have a bit of upregulation. So PIK3CA is working too hard. And when PIK3CA is upregulated, then AKT is upregulated and mTOR is upregulated. And it leads to the abnormalities that you have. And how I explain it to like an 8-year-old is, you're a dressmaker and you make the most beautiful dresses, but you make only 5 a week. And your people are calling from all over the place to come and have your dresses. And so your boss says, you know, I need to make more money, so I want you to make 25 of these dresses next week. And you start out and you stay up all night to make those dresses, and the first, 15 of them are perfect, like you always make them. But by the end of the week, you're going to be tired, and you might miss a stitch and all of that. So the vessels and everything else in the upregulated, something's working overtime, are just not normal. The walls are a little more dysplastic. The muscle layer is not exactly right. The cells that line them are not, there might be gaps in between them. And that's true for the capillary component, the lymphatic component, and the venous component. And that's where some of the problem is. What I say to my cancer friends is, you got it easy. And that's terrible for me to say. I have a lot of cancer patients, right? But I did have a mother come up to me in clinic, and actually one of the dermatologists talked about this at ISFA, and she said to me, you know, I don't mean to say this to you, but I wish my kid did have cancer, because then you know exactly how to treat it. And she's right. A cancer is a cell that's one cell that's growing out of control. And if you can figure out what it is about that cell, we don't have one cell growing out of control. We have an abnormal endothelial cell, we have an abnormal wall, we have abnormal muscle. It's much more complicated than that. And so whenever my patient, my group is sort of saying things, I point this out to them. And cancer, the majority of pediatric cancer patients are cured. So our patients are with us forever. And that's why it's so critical, the whole transition thing, to find doctors that know how to take care of you guys. So does that make sense? So that's just one side of the pathway. Like, this other side of the pathway came about, we didn't even know this was going to come about, right? The other side came about because we were looking for all of these other things. And we knew about the RASopathies. We didn't know the extent of the RASopathies. But we didn't know all of these other things, like the complicated lymphatic anomalies that fall onto the other side. And Melanie, you're going to need to tell me about time and stuff, because you know I can go on forever. So does anybody have any questions? Yeah.
Can you go back to I see alpelisib is up at PIK3CA.
Yep.
And sirolimus is down at mTOR.
Yep. Yeah. Well, I'm going to talk about each of the medicines, but I will talk about that now, because just in case we don't get to that. So first of all, sirolimus was the first drug that we had, because it was the only, those weren't, that middle part wasn't even there, right? The first version of this was just without all the drugs. And we came about mTOR because we really felt that there was because of some of the other disorders that were being taken care of with sirolimus. We also knew that some of the things like tuberous sclerosis had very vascular lesions that were being affected. And I had a nephrologist, a kidney doctor, come and talk with me and say, you should really look at the mTOR pathway before this all came about too. It was sort of like just kind of a weird set of a turn of events that happened. And so everything is upregulated. So this does work. And mTOR is a very interesting component to this, because mTOR is probably what also is overexpressed in the other side of the pathway, okay? So, but what our thinking is, and this thinking goes back to oncology, so this is what it's based on. If you can decrease something where the issue is, you're probably gonna have better benefit. And so that's why there's a question, and we still have to answer this, right? We still have to answer this because sirolimus has some other properties, like it's an anti-inflammatory agent as well that helps disorders too. But so there's a question of if you block where the problem is, if that is more beneficial. The next drug is moransertib, which, and this is a problem that we all are going to have as well. So I might as well just keep talking about this stuff. So moransertib is an AKT inhibitor. There was an AKT, remember I talked about Proteus. Proteus, the gene is AKT. So the people at NIH had a trial for a Proteus inhibitor, and they needed more patients, and so they said, let's see if we can get the vascular anomaly patients, the PIK3CA vascular anomaly patients, because it's one up from mTOR. It might be a little bit better than sirolimus, and it doesn't have as much immunosuppression, that kind of thing. And so they asked us to be part of the study, and the study opened, and it actually was, I don't think anyone, was anyone in this room on the moransertib study? So some of my patients were on in Boston, but it was a very good study. A small number of patients, so you can't say whether it was effective, but I can tell you the patients that I had on it, it was effective. And it didn't have as many mouth sores, it didn't have some of the other things. But what happened was, it was a small pharmaceutical company that was bought by a larger pharmaceutical company, and then that larger pharmaceutical company did not want to move it forward. So the people who were on the drug and had benefit from it were allowed to stay on the drug, but it's not being, now, we are looking at other AKT inhibitors because I think that's an area that we need to go into. But those are some things that we also are going to need to deal with. Like, we don't have the National Cancer Institute that has access to medicines. We are talking to them. I go there every 2 months to work on this vascular tumor chapter, and every time, and they're actually adding malformations to the chapter in the next year, which is a big plus for us. But I'm talking to them about why can't we have access to drugs, right? We have to rely on our pharmaceutical companies as well, but sometimes that happens where they're bought and that medicine is no longer, we don't have access to it. So, and this is why we're going to need all your help to help us. So does that help you with your questions? And I do have some other slides on that as well, but please continue to ask. So I'm just going to talk about like what our dilemma is when a patient comes in to see us, and how I am a very, I don't know, what would you call me, Brian? I'm a very like boom, 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 process-oriented person. So when rule follower too. So except when I need to break the rules for my patients. So I have done that. So when I think about something, I do think about like the process. So if a patient is referred to my center, why are they referred? Like, who referred them? Did the physician refer them? And why were they referred? Like, what did they say they're coming for? What are the patient's and the parents' concerns? So that's like your biggest issue. What are the patient's symptoms? What do I think the patient's diagnosis is? Like, we try to have pictures, we review the patients before they come in to see us, just so we also know the specialists that need to see them. So we won't give them a diagnosis then, but we'll just think about it. And then when I see them, what is the diagnosis? What are the tissues that are involved? What are the vessels that are involved? What are the imaging studies that are needed? Do they have all the imaging studies, or do we need to do more imaging studies? And then I always think about what are the risks that I have to worry about, because I have to worry about them, but I'm big on education too. I've done a lot of things with education in my life with fellows and everything else. So I need to make sure that I know what to worry about now, when that kid goes through puberty and when that kid is older, and I need to make sure that the parents and the child knows that as well. And then what is the best intervention and at what time? And so when we talk about someone, when they're reviewed in our conference before they come in, we talk about all of this, but we also think about all of this as we're evaluating the patient. So when I think about a patient, I think about what's the phenotype? What do I see from my clinical exam, or we see from our clinical exam? What do we see from the radiology, right? Because that's really important to us, because we might not see a lymphatic component, but the radiology might show us a lymphatic component. And then what do we see from the pathological evaluation? We might have that, we might not have it. We don't need that on every patient, but it's part of what that phenotype is. And then now we're very lucky that we have genotypes. So mostly those somatic changes, because we have to think, is there a causative gene? Is there anything that's inherited? So is it a germline gene because it's inherited? Because we do take care of other things like the RASA1. There are some inherited venous malformations. We take care of patients with this thing called P10 syndrome that have vascular anomalies. So they're part of this as well because they have vascular anomalies. Like, do we think it's a somatic mutation? How can we identify it? Has there been tissue done? What other things can we do to see if we can link the two? And if we need to, do we need to identify that gene now? Is there a reason to, or do we wait? So those are the things with looking at this, okay? Yes. Somatic to me, if you look, somatic means body. So those are our body genes. And when I explain it to little kids, I say, we all don't look alike. We have our dad's eyes, dad's wrist for hypertension, whatever. But guess what? We're all human beings. It doesn't matter what your color is. It doesn't matter whatever. We all need hands, skin, muscle. And that's what a somatic gene is for. So this patient's phenotype looks like a capillary, lymphatic, a little bit of lymphatic because this patient has blebs, right? And venous because there were some ectatic veins. This was a picture that they showed us beforehand that the parents took. We think that this is probably KT or cloves because there are some abnormalities of the toes that look a little more like cloves than KT, but we think it's on the PIK3CA spectrum. And then what happens when but you have this, and this seems very straightforward to us, right? So I can, and I'm going to talk about what we think about for this particular patient. But think about what happens if the patient doesn't quite fit into that category. And there are many people who don't quite fit into the category. So, gosh, this is capillary malformation with overgrowth. Is there diffuse capillary malformation with overgrowth? Is this PIK3CA? Is this not? Is this just a capillary malformation? You know, there are many patients that don't quite fit in or have a little bit of this and a little bit of that. And does it matter? We still take care of them the same way. Sometimes the genotype matters because if it's a patient that needs to be treated, we want to make sure that it's on one side versus the other side because we use different medicines. And I don't think I answered your question about the dual medicines. Did you ask a question about, okay, because if anybody, yes.
I didn't ask a question about the medications, but a few conferences back, someone was talking about the difference between like modeling versus geographical. Does that have anything to do with possibly what phenotype or genotype you would fall under?
Well, so when we think about things, we do think about like, what does that look like, right? What does the stain look like? We also think about, is a lesion multifocal? Is it local, right, in one area? Is it multifocal? Or is it diffuse, right? Is it diffuse? And that is important. And sometimes for capillary malformations, you'll look at the geographic distribution to them because many times, depending on where something is, you also have to worry about other things. So I'll give you some examples. So if you have a capillary malformation and it's on top of your butt, right, around in that area, sometimes there's increased risks for you to have something wrong with your spine. So when a baby is born and has a capillary malformation over that area, we do an ultrasound. It's very, very, very rare. So our dermatologist was bringing this up, do we really need to do this? And I got him all the old articles that said that there are things, and you don't want to miss something, right? It's sort of like the rareness of a patient that we don't know whether they're more susceptible to Wilms tumor or not. It's an ultrasound. So if we have any kind of question, it's easy to do. If you have a capillary malformation that is around your rectum, right? We know that those patients have, and again, we know, I'm saying we know. So we know this from years of experience, right? We don't know this from doing a registry to look at what those issues are, because we're going to talk about this later when we talk about why we're applying for these grants. We know that from being at other centers, Steve Fishman and I always used to look around the rectal area, and if someone had, a significant, if it was like a KT patient around that area, I better look to make sure that there were no veins, abnormal ectatic veins in the rectal area, because they probably have an increased risk for rectal bleeding. But also, I better look at the abdomen to make sure that the portal system looks okay as well. Small percentage of patients, but the significance is significant. And so simple thing to do an ultrasound. So it is geographically, and where something is does matter. Yes?
The one thing that I want to answer for you is you said, does it matter? Okay? It does matter.
No, that's why I said it matters.
It is very important to the patient.
Yeah.
That if they're somewhere on the spectrum, that
Yeah.
you tell them you lie somewhere between here
Yes.
and here. You have some symptoms of both.
Yes.
Okay? This is what we're going to address because this is the most threatening. Okay,
Yeah.
Or whatever. But you also could fall into this other range. And
Yeah.
the reason for this
Yep.
is they need an identity beyond you are one of 14
Yeah.
diseases.
Yeah.
Okay? They need to know that they are not going to have symptoms of something else that's entirely different because it struck a different area of the body or a different timing or whatever. They just need to know on a scale of 1 to 10, you're right here.
Yeah.
And these are the things that you might see.
Yeah.
Because when they go on the internet and things are all lumped into one, okay, new parents are scared to
Yeah.
death
Yeah.
by what is out there, and it is listed under PCA-related overgrowth spectrum. Now, I get that. I do get it, and it is very clinically important for you guys to look at it as that. Okay?
Yeah.
But it is equally important for the patient to have something to identify with so that they can discuss it with themselves, their families. They have a better understanding.
Yeah. Yeah.
And
Yeah. No, I agree with you. And I guess I shouldn't have said it doesn't matter. It doesn't matter because we treat, yeah, you certainly did, Melanie. It doesn't matter because we treat you the same, right? I mean, well, I should say the vascular anomaly centers that know about these things treat you the same. And we do, if someone is in between, we do, like, I pride myself on telling my patients everything that they need to know. So understand that medicine is not an exact science, and there are many times that we don't know. There are many times that we are puzzled, especially with these rare diseases. And I think it's only fair that we say that to people, and we say that to people. But the problem with being too... So when something doesn't fit, you have to say it doesn't fit. It looks a little like this, it looks a little like that. But that sometimes makes people more stressed if they go out and they look at those both things. So, I think the most important thing is that you have to have every trust in the world where you're being taken care of, right? So, I mean, I know, but,
You struck another nerve, Dr. You struck another nerve.
no, what?
You should ask how many of these people trust their caretakers.
How many people trust their caretakers?
Okay. We discuss this some more.
There's 3 of us
No.
here. I trust you.
I have to say, she is an anomaly, she's an exception.
Yes.
She will tell you where you lie on the spectrum, and I'm not trying to pick one what I'm pointing out.
You are picking on me, Melanie.
So,
Don't give her a microphone. Don't give her a microphone.
the thing is that it is up to the patient to ask these questions.
Yes,
But they
yes.
have to know the terminology
I
to
know,
ask.
I know,
If
I
you don't
know.
know the terminology,
Yeah.
you're lost. And
Yeah.
depending on a doctor who does not have
Yeah.
information that is telling you incorrect information, and
Yeah.
you don't know how to connect with your population.
Yeah, but
And you saw how important that connection is last night.
do you want to? She wants to be a debate with me. A debate.
No, I'm on your side. I truly am.
No, but let me tell you, this is why Brian is doing what he's doing.
Correct.
This is why when you know this youngin came to me, he's not really a youngin anymore. I was like, yes, like, you know, he's going to do great things. Like, I'm not going to be around. He's going to do great things. We have the underlings are just fantastic. They're out there. I mean, we're forming this consortium. Our lack is the adult care, and we have to work on that. We have to work on that. And you have people like these groups that are going to help. But yes, we're lacking. Brian showed you areas of the United States that we're lacking, but look at those areas that we have, that we didn't have before, that we're training. You know, we're training more people at a younger age. We're going to be training other people, not only hem-onc people, pediatricians, other dermatologists, to help you all. So, do you want to say anything else, Melanie?
No, other than that, you are on our side and we know this.
But we're working.
And Brian is, and she sent me Brian. So you know that she's on our side.
I'm very picky. I'm very picky.
Yes, and so are we.
But there's much work that needs to be done. Much work that needs to be done. And I do think that you should be the best advocate. I mean, that's one thing that I do when I help my patients try to figure out, hey, I've been in the adult system. My brother died of ALS, you know. That was the worst experience that I ever went through. So, but I was right there, and I was a thorn in their side, like all the adult medical people's side, but I got things done, right? I mean, you have to be your best advocate. And I think we have to teach people to be their best advocate. We have to teach the children, the kids, to be their best advocate. You know, so you were hearing about, you know, talking to the kids by themselves, all of those kinds of things. So, so I do think, yes, Judy.
But I'm not exactly sure that Mayo Clinic doctors even knew Boston doctors, who even knew Cincinnati doctors. We didn't have computers.
No.
You know, you guys don't really realize what technology has done, and
Yeah.
you know, you're very isolated. You still feel that way, but you aren't half as isolated as you were before computers and before when all there was medical literature, which doctors had to go to libraries or subscribe to themselves. So it's come a long way. It's just that every generation thinks that you're, you know, reinventing the wheel again. So hang in there. You know, it will get better. It's always, you know, your children's children will benefit from what goes on today, but it has changed. Things have gotten better. There's medication that back in 1986 you couldn't even imagine that there would ever be a medical solution for some of this. It was compression stockings, perhaps surgery to take out some of the bulk. So it has come a long way. People like Melanie and Denise and Brian are pushing the rock up the hill. And as I think people pointed out last night, it is a very small population. You could put all of the KT people probably in one doctor's practice, and it would still be a mighty little practice, you know. So when you've got 2 people in your practice, you aren't going to probably start a vascular clinic out in Nebraska. task. You know, you're gonna have to have centers, which is what Denise and the people will talk about applying for. So, don't lose the faith and do whatever you can to educate yourself, which I think is what Denise is trying to do today, to make it better for yourself. You know, the more you know, the better it will be. And I guess I just keep saying, you know, it has gotten a lot better, guys. You know, so hang in there. So that's my words of wisdom.
All right, I'm going to have to go through this a little bit quicker, I think, because I want to talk a little bit, yes?
She has done so much as well.
Yes,
for the
yes, she
baby
has.
crew. I mean, her in-laws used to babysit us. So, I mean, she did a lot to start all of this.
Yep.
This is the children and the children reading in what they taught us. But one, I have two questions. One, whenever I get an infection, I get it on my left breast. I don't know why, but 3 days later, you can time it, and I get an infection. I just had surgery to remove a tumor on my hip, and he's a research doctor. He was really neat. He spoke Arabic, so I was practicing my Arabic on him. But he found 2.5 inches of KT wrapped around my abdomen, and I've been seen at the Mayo Clinic since I was a baby. And I've had all the tests, the MRIs, and now they're just diagnosing me with more KT in my abdomen. Is that normal?
Do you know what kind of tissue it was?
It wasn't because I like pictures, I make them take pictures.
Okay,
Because I want to see the tumors. It wasn't like the KT, which is the tubes, like when I was dying, the gangrene. It wasn't like noodles with the lines on it. This was more like really small noodles. And they were all because I had gangrene and I was dying again. My organs were shutting down. And I made them take pictures so I could see
yeah.
I'm married.
I'd be more than happy to talk to you about it, like afterwards, to see if we can figure it out. So sometimes when things are removed, other things change, and sometimes you can get dilated little capillaries or dilated veins, but yeah, yeah, yeah,
They said it had been there, the surgeon
yeah.
said it had been there a long time because they were removing a tumor, scraping it from my right hip.
Yeah. I'd have to look at all the information, but I'm more than happy to talk with you about that. Yeah, try to figure it out. So talking about like how things change. So when I first started this, again, a dermatologist sending me things, and he would say, treat this kid with interferon, treat this kid with this, and I just was like, this is insane, this is crazy. And every time something was out there for like hemangiomas, it was used for vascular malformations, and they're totally different. So propranolol is something used for hemangiomas, and it started being used for every kind of vascular malformation. And the same thing with steroids and other chemotherapy medicines. And so this is what I felt like, and this is one of the other reasons. Yes?
So I think propranolol for anxiety.
Yeah.
What does it do for vascular malformations?
It's complicated. So you take it for anxiety because it decreases your heart rate and things like that. It decreases blood flow, and that's what they thought. They thought that those ways that it works by decreasing blood flow, decreasing your heart rate, it also decreases one of the angiogenic factors called VEGF. But what they're finding now is there's two types, they're called enantiomers of propranolol, and one of them specifically, and it's not the one that causes those effects to decrease your anxiety, it's the other enantiomer that actually regulates something called, it's another gene called SOX18 that is involved in the vascular genesis pathway. So it has two things that it does, and probably the form that's helping your anxiety, and actually a lot of people take it, a lot of like my residents, I was finding out, were taking it for stage fright. So people take it for stage fright, they take it before they're doing talks, that kind of thing. But totally different reason we found. So, yeah, good question. Yes?
So I was given gabapentin and duloxetine that was stacked where I was supposed to be on like a higher dosage throughout the day. But I noticed that I was getting really So sort of where my joints at the top of my shoulder, I would get really weird headaches. Is there a reason behind that? Because I would figure that the gabapentin would reduce the headaches.
Yeah, so gabapentin is like a thing that helps with neuropathic pain. But gabapentin has a lot of side effects to it. And also sometimes when we're on medicines, they can affect the vasculature in different ways. So I'm always surprised sometimes when you give a sort of very common medicine that can make things swell and not. So I've never heard that before with the gabapentin. It might have been a combination of those two medicines. Yeah. Yes. Yeah. 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 And I think that's important because sometimes medicines, when you have a particular diagnosis, might cause different kinds of side effects. So really make sure that people understand what your signs and symptoms are of your vascular disease, so that if there is an unusual side effect that occurs, who knows what that's from. I always think there's a possibility for those things. Did you have a question, Kat, or? No, okay. So this is that patient that had the KHE lesion before she was treated with sirolimus and then after she was treated with sirolimus, and it really did save her life. So you guys know about sirolimus mTOR inhibitors. You've heard some questions that were asked yesterday. We have learned so much about sirolimus since we had the first trial. There was a trial on sirolimus and vascular anomalies, and it worked in about 83% of patients to help. Remember, when we're describing outcomes for our patients, our outcomes are a little different than for oncology. Everybody wants our outcomes to be a decrease in the size. So imagine, right, you have a lot of overgrowth, right, and that overgrowth of your leg or whatever on sirolimus or on alpelisib has gotten very soft and mushy. It's not like, these people, we describe these things. And then you get on an MRI scanner. What's happening when you're on an MRI scanner? You're flat, and that floppiness of that lesion, it's the same, right? So it's stable. Sometimes people actually have shown that even though their clinical findings are better, that MRI might be a little worse. So that imaging endpoint might not be the best endpoint to have. So in the study we had with sirolimus, we actually looked at radiology, quality of life, and pain, and we put them on the same score. So you had to have improvement in all things to have a complete response, but most people had a partial response or were stable. So stability to people, if it's improving their clinical benefit, is good, right? Yes, we want it to be completely gone, but stability is good. And these are the problems that we have, because when we go to the FDA and we go and we write these trials, they're wanting us to do things like an oncology patient, and we're not. We need to think about alternative endpoints, and that's one of the things that Brian is doing. Does anybody have any questions about sirolimus? There's a lot of things about, when we first treated patients, the study was for high-risk patients. So we used, sirolimus is great because it has levels. And so we used a higher level, and for infants, that was an immunocompromising level. But now we don't need those high levels. And actually for adults, I do sirolimus totally differently. So I use an adult dose, because if you treat an adult with a high dose of sirolimus or even alpelisib, and they have side effects right away, they're not going to want to be put back on that medicine. So I have a different way of treating adults. We have a different way. It's sort of Brian is working on sort of with Sally Cohen Cutler, what is the practice that people are doing now with mTOR inhibitors? So, but I don't think you need to be as worried about immunosuppressant levels. If you look at, I just copied this last night, but a long time ago, when I first started this study, there were researchers at UVA and other places that were using sirolimus for mice, and they were also using it in dogs to prolong survival. And this is an NPR article where they're using rapamycin for aging. There's like 300 scientists out there that are taking a small amount of rapamycin to prevent aging, and a dentist is using it to actually prevent gum disease as people get older. So just to have that. But does anybody have any questions about sirolimus in general? Yes. Yeah, it's a different, so gum is a degenerative kind of inflammatory thing, and the mouth sores are because of how it affects the lining of your mouth. Yeah. And so it's okay, Kat, she's learning something. So, for example, when people have braces on, you know that those patients on sirolimus are going to get mouth sores because the braces irritate the lining of your mouth. So I always, will tell kids if they have braces, make sure you put that wax on and have it in all the different areas. So, but yes. That's a very good question. So the other medicines that are more direct, so say I think that we, because it's never I should never be saying I, it's we. So we as a team, right? We as a team decide what the best therapy is for a patient. At least that's how we've done it at all the places that I've been. So if we think that someone needs medicine, it depends on the severity of what they have, right? Do they need it now? And do they need something that I think we think is going to work the best? What's their age? Because alpelisib is really hard to get for people who are less than 2. You can, but it's very hard. It's been conditionally approved for 2 and older, so it's easier to get alpelisib, though some insurance companies give us a hard time because it's very expensive, but I know our people from Novartis are going to be working on that and accessibility of the medicine because it is very expensive. So it really depends. I take all of those things into consideration. So, for example, last week I had a patient that had probably a pretty significant Klippel-Trenaunay that this child was born, new prenatally, and we started with sirolimus almost right away. So not. In older patients, again, it depends on why we're treating. So what are the symptoms? What's the disease extent? What's the risk? If a patient comes in and they have capillary blebs that are leaking, right? Because they have a lymphatic component and they have a lot of overgrowth, I might say, and do we know the genotype or not, right? So sometimes you might not know the genotype, and an insurance company might say, you can't have alpelisib until you let me know that there's a PIK3CA mutation, and we search for that because we have ways we can do it with cell-free DNA. I might start, if that patient needs medicine now, I might start on sirolimus and then change over to alpelisib. If there's a study available, we might, consider putting on a study. We just think about all the different opportunities that we have. But I don't routinely, start necessarily with sirolimus anymore. So we really think about sort of what someone has.
So it's just a case by case.
Yes, because, say that again? Yeah, so that's a really good question because Brian and I were talking about that yesterday. So there are more drugs coming down the line, and we need more drugs, right? We cannot just get by with 1 or 2 drugs. That's not fair. Think of all the drugs there are for Crohn's disease, right? So we can, but when we have these new drugs, we sort of have to prioritize. Okay, so who would these drugs be for? you know, as a center, as a team. And we have a big consortium now, and we have another consortium that we're applying for that hopefully will be helping with a whole bunch of other experts and patient advocates to help us try to make those decisions. So, because that's what we need. And most places, so even in the oncology world, have risk stratifications for people, but they also have, if someone has relapsed, they each have in their thing, okay, so this should be our first thing that we go to, this should be our second thing. You know, we really have to do a better job doing that. Yes, can I just take, yeah.
Sorry. So you said that you tend to use different dosages for adults and for children with vasculitis. What is an example of, like, is our adults higher, are they lower?
Yeah, so I do this, we do the same thing like when we have a patient. So what's the risk of this patient? So do I have to treat at a high level, like 8 to 10? I never use above 10, usually. Can we use a medium level or a low level? And in adults, like 4 other studies, like there's a disease called LAM. The adult dose is 2 milligrams a day. And again, I know if I'm going to start an adult and I start them at 2 milligrams and they have a mouthful of swords, they're not going to want to take it. So I actually usually start sirolimus at 0.5 milligrams for a week or 2, see how they do, go up to 1 milligram, and then try to go from there. Some people will be fine at 1 milligram, and then why do you need to push to the higher dose? More is not necessarily better.
Yeah, I was mostly asking, I was on it for a little over a year, and I think I was doing half a milligram twice a day, so I was on 1 milligram a day, and I asked if we could go up because I knew that my pain could be treated better. And she was like, well, no, your levels are good, so we're not going to change it, and
Yeah,
I think you're fine.
So how we usually do it is go with the symptoms, right? So we try not to be at an immunosuppressive level, but we use the symptom relief. You know, it depends. So when we start someone, I have this little plan, and I say with the patient, what are we doing this for? Like, what is our purpose of this? Improve functionality, improve pain. We write them down, right? I usually also have a patient do a diary beforehand so that they are keyed in to what the issues are. And so then we work on it together of what we're looking for, right? And then I grade that. So what's their pain? Like, is it mild, moderate, severe? I don't do the numbers. I grade the dysfunctionality and kind of do it that way. So, does that help? Okay. Yes. So if I'm going to go real quick. So we talked about moransertib. I talked about how I really felt that was a good drug. Alpelisib. Let me go back to this because I'm sure that many of you have some questions about this. But these are the RASopathies. So RASopathies can be AVMs. They can be lymphatic malformations. They can be a combination. And there are MEK inhibitors that we're using now. There's no RAS-specific drugs, but we're working on that. And there's also people that have RASopathies like BRAF and KRAS, and there are some specific medicines for them, but it's very interesting in the oncology world. Sometimes those diagnoses work best when you treat with 2 drugs rather than 1 drug. So there's many, many things that we need to figure out in this pathway. So how many people are on alpelisib? So just 3, 4, okay. Yeah.
Hello, sorry. Do you ever find that you can help zero in on what a diagnosis is based on how someone was affected or not by alpelisib? Because I tried it for a year, and we were pretty sure that I had KT. Alpelisib only made the situation worse for me. And so can you use that to sort of zero in on what the actual diagnosis is, or is it just not enough information?
We don't have enough information now. I can tell you, just like, so for sirolimus, we had, so it seemed it worked great for those tumors. It worked great for lymphatic components to the disease. And so we really honed in on what someone had just to make sure we knew that. We really made sure for the studies that are being done now, and I think I can say this, that we classified what the phenotype was so we could pick up things like that. But there's also, so what does this patient have? So, steering committee, there's a steering committee that's part of every study. And, it's really important for them to be really tremendously involved. And I think that for a study that lumps all of PROS, you have to know, am I dealing with a patient that has KT, or am I dealing with a patient that has closed and it's mostly lipomatous overgrowth, or it's closed with vascular anomalies, or it might be just a lymphatic malformation. And we don't know the answer to your question from that study, but at least you know that the people who are looking at that have been identified with what we thought was the best phenotype. Does that make sense? So the physicians gave them a diagnosis, and then the steering committee went back and sometimes corrected that diagnosis. So when they're done with their evaluation, hopefully they'll be able to look at how many patients with KT responded. But what you're not going to get is, remember, KT is a spectrum of things as well. There's so much heterogeneity with it. So is it KT that has more lymphatic component that responds? Is it KT that has more of a venous component? It's hard. And so those are going to be, and the other thing is that there's different types of PIK3CA. So you also have to look at the genotype too. So I can, like I said, we've had patients that have had the same genotype, given the same diagnosis KT, that each look completely different, that respond differently to drug. So that's the hard part too. This is not cancer. So, when someone comes to me who has cancer, I can tell them what the exact diagnosis is, I can tell them what their risk is, and I can tell them what their overall outcome is going to be. So did you get worse, or?
Yeah, I had some pretty severe side effects, and then I started getting infections.
Yeah. And yeah. And so it's not gonna work the same on everyone. So this is just a gestalt, right? So, we really have to figure these things out scientifically, but this is just a gestalt. I think that alpelisib has done an amazing job for some people with bulk. I don't think, at least in the beginning, it works as well with lymphatic blebs. And I think sometimes you see an aggravation of those areas first, but it takes a while to see actually a response. Probably 6 months, but sometimes it doesn't work as well as like sirolimus would use. So not for the patients that are on the study, but for other patients that are having other areas of response from alpelisib and are not having side effects, because we do know that there are side effects. We'll use topical sirolimus for the blebs with the alpelisib, and that seems to help. But if you were having side effects, that's not going to help your side effects. And a drug it's not going to work. It's not going to work for everyone, which is why it's so important that we have the studies that are looking at these side effects and looking at them in the right way, right? Because it might, so do you guys know how we do side effects? My patients know, because when they come in, we grade them. So grade 1, grade 2, grade 3, grade 4. So you have diarrhea. So grade 1 is you're just going more frequently. Grade 2 is maybe it's a little bit looser. Grade 3 is that you're really like more than whatever your normal. So it's really important to find people's normal before they start drugs. Grade 4 is that you need to be hospitalized because you're dehydrated because you're having so much diarrhea. So for everything, we need to do that. But a grade 2, which might be mild, if it's interfering with your quality of life, hair loss, right? So hair loss is a big thing that we see for some people. If your hair loss goes on and that is really interfering with someone's quality of life, and it goes on for more than 2 weeks, and something needs to be done, whether that's a decrease in the dose or whether, you talk with your patient and you feel like someone needs to come off or not. Some people are more in tune to the grading systems and everything else, and I think it's our job to really make sure that that's done in the right way so we can capture like the real side effects of what's happening with these medicines. Yes?
So you talked yesterday to me about your knowledge of what's going on in Canada and some of the work that's done, and there's an actual conference. Is this drug soon to be approved by Health Canada? Because I know it's not now.
No. Do you know about Health Canada? I don't think it's close. Yeah. Yeah. Yeah, and I'm not either. I know that people can get it in Canada because I have people in Canada. Well, I don't have them, but I know of that group that treats people with alpelisib in Canada. And there are other drugs. You have to petition. It's sort of what we had to do with this before there was this managed access protocol from Novartis. We had to, and for these other drugs, for the other drugs that we have, if they're not approved for our indication, we have to go to the insurance company and say, in Canada, you have to actually go to the Canadian government, I think, to get that. So, does any, Kat, we have to stop, okay. Do you want to just say something, though, about, can I just say something about Canvas and stuff? But do you want to say, while I'm getting these slides on, like your experience? Because people have different experiences with alpelisib. And I don't think it's the be-all and end-all.
I can talk about mine, too.
I don't even know where to start. I mean.
Kat, why don't you talk about, like, how are you feeling now compared to?
My life did a complete 180. So it was a lot of adjustment, but I didn't notice the changes until I was about a year in. But I don't know if I would even say right now I'm plateaued. I still feel good. I can walk further than I've ever walked in my entire life. I have more energy. I don't know. My life completely changed, but it's not going to work for everybody. That's the problem.
What are the downsides of it? I know there's something about your heart and stuff like that.
So, yeah. Carbs and sugar. Your diet is very important because your glucose will go up. You have to watch it, but your doctor should be monitoring that. For me, the biggest part, honestly, was the psychological part of it because I was born with so much pain. I'd only ever lived in physical pain, so it was very hard to adjust to, oh, I feel good now, but your body is used to being in a fight or flight, and once it doesn't regulate. So you have to readjust everything you do, your mind, everything changes.
And what about size? Did you have size differences?
Yeah. I'm back in compression now, but I went from compression at 18 months old to out of compression, and I was out of it for 4 years. I'm back in it now, but my leg probably shrunk. Yeah,
I think I had a 65% reduction in my arm, and probably my back, too. So.
Yeah, I lost, quite honestly, weight and everything, I lost half a person, so.
But everyone is different, and we know the short-term things, but we don't know the long-term issues. And we know that with sirolimus, we would try to give people sort of drug holidays. We're still talking about, like, what do we do for alpelisib with that? So there's many, and not everyone responds in the same way. And that's why we need studies to really understand, like, who are the people who are going to respond and what are the side effects. Sometimes you can have increased anxiety from the medicine. Sometimes you can have lethargy. Sometimes, so there are amazing responses, but then we have to think about all those things. That's why it can't be done haphazardly, like we have to have clinical trials.
So are you on this drug forever then? Because on one of the slides you showed, you said 18 months off and then recent, so they stopped the slides?
Well, that was sirolimus that we used to kind of give them time off of it. And we don't know what to do yet. I have some of my patients who have been on alpelisib for 4 years now that I'm starting to decrease the dose and to try to see if I can give them some time off, because this is a chronic condition, and so theoretically you're going to need to be on it forever. So maybe you can get to the least amount of medicine that gives you the best effect. And just quickly, because Kat kept giving me the time, Canvas is the Consortium for the Investigators of Vascular Anomalies. It's something that we started. We got all the contracts signed probably about a year ago. We have 23 sites now. We just added another site. We have 2 patient support groups that have been part of it. It is housed in It's housed at CHOP. It's housed at CHOP because when I went there, I told them that part of my package needed to be money for this. We need more money because it takes a lot to run a consortium, so we're applying for more grant funding and things like that. But we will be doing some studies where we're looking at genotype and phenotype. Our mission is to improve studies for vascular anomalies. We've had some days at the ballpark to actually help us get some funding. So we went to Kannapolis, we're going to the Durham Bulls. If anyone is interested, ask Melanie. We have 2 studies that are up and coming. One's for alpelisib for anyone with a PIK3CA mutation, and the other one is for trametinib for patients that have the other side, the RASopathy mutations. And we're looking at an individualized patient response criteria, so it will be new, and hopefully NIH will be keen on this because it's not just looking at radiology. And then, so we are applying for something called a U54. It is a big grant. It is, believe it or not, so it's $1 million, but there's tons of different projects that they want us to do. It is a very cumbersome, it's $1 million for 5 years. You can renew for 5 years, so there's a potential that we could get 15 years of this. And it gives us leverage at the NIH that they know what vascular anomalies are, and we get to use like this data monitoring collaboration center that they have, and we get to work with other rare diseases and help each other try to figure out about these rare diseases and how to use outcome measures and all of that. So it's called ARTVAR. It's Advancing Rare Disorders, Vascular Malformations Research Network, and it's going to be with Canvas. And it is made of Canvas. We're partners, and we have a bunch of advisory boards, and many of you have been asked to be part of the advisory boards, and Melanie is in charge. She's our chair of our advisory committee, and she'll be part of the advisory committee for all, if we get it, for all of this consortium. So we're going to, at some point in time, ask you to write letters of support, if you so deem, this afternoon, so deem to, and take pictures of yourselves, if you agree to have the pictures taken. We had people do this for us. We tried for this 5 years ago, but the NIH really didn't know who we were. As I said, this year they asked for vascular anomalies, even though they got some of the terminology wrong. And these are all the things that we need, and we're working on with the help of all the young people in our field who are stepping up and have become interested. And it's so amazing to see young people like Brian and everyone else start to be involved in this, because I think this is going to be a much better world for all of you in the next 5-10 years. So thank you very much.